So let's carry on. I've noticed that the first video, the voice was really bad. So I hope this is better. I've used my fancy microphone my brother uses for his. The last video was just with my AirPods, so it was really bad. Uh, I'm not even sure if this is working, but even if it's just my iPad recording, I believe it's gonna be better than the last one. So let's get into it. So let's start with the red blood cell. Erythropoiesis. The red cell precursors pass through several stages in the bone marrow. The earliest morphology recognizable cells are pro-erythroblast. Smaller erythroblasts result from cell division, and precursors at each stage progressively contain less RNA and more hemoglobin in the cytoplasm. The nucleus becomes more condensed and is eventually extruded from late normoblast in the bone marrow when the cell becomes a reticulocyte. Reticulocytes contain residual ribosomal RNA and are still able to synthesize hemoglobin. They remain in the marrow for about 1 to 2 days and are released into the circulation, where they lose their RNA and become mature red cells, erythrocytes. After another 1 to 2 days, mature red cells are non-nucleated biconcave discs. Nucleated red cells, late erythroblasts, are not normally present in the peripheral blood but are present in extramedullary hemopoiesis. And some marrow disorders, see page 366, about 10% of the erythroblasts die in the bone marrow, even during normal erythropoiesis. Survival of the erythroblasts is dependent on erythropoietin cell signaling and the natural 10% excess production of erythroblasts. Ineffective erythropoiesis ensures a rapid drop in hemoglobin, e.g., with acute hemorrhage, hemolysis resulting in a rise in the erythropoietin production and cause a rapid increase in terminally differentiated red blood cells. Ineffective erythropoiesis is substantially increased in some anemias such as the thalassemia major and the megaloblastic anemia. Erythropoietin is a hormone that controls erythropoiesis. This heavily glycosylated polypeptide with a molecular weight of 30,000 to 400 DA is produced in the peritubular cells in the kidney 90% and in the liver 10%. Its production is regulated mainly by tissue oxygen tension, increasing production in the face of hypoxia, e.g. with anemia or cardiac or pulmonary disease. The erythropoietin gene is one of the number one of genes that is regulated by hypoxic sensor pathway. The three-end flanking region of these genes has a hypoxic response element, which is necessary for induction of the transcription of the gene hypoxic cells. Hypoxia inducible factor 1 is a transcription factor which binds to hypoxia response element and acts as a master regulator of several genes that are responsive to hypoxia. Erythropoietin stimulates an increase in the proportion of bone marrow precursor cells committed in erythropoiesis by allowing greater number of erythroid precursors to survive, and CFUE colony factor unit, facilitating unit, I think, E, which indicates erythrocytes, are stimulated to proliferate and differentiate. Increased inappropriate production of erythropoietin occurs in certain tumors such as renal cell carcinoma and from other causes resulting in secondary erythrocytosis. Hemoglobin synthesis. Hemoglobin performs the main function of red cells, carrying oxygen to the tissue and returning carbon dioxide from the tissue to the lungs. Each normal adult hemoglobin molecule, A, has a molecular weight of 68 kDa and consists of 2 alpha and 2 beta hemoglobin polypeptide chains, A2, B2. Hemoglobin A comprises about 97% of the hemoglobin in adults. Two other hemoglobin types, hemoglobin A2, hemoglobin A, and gamma 2, and hemoglobin F. So this is delta. A2, delta 2, and hemoglobin F, which is the fetal, alpha 2 and gamma 2, are found in adults in a small amount, 1.5 to 3.2% and less than 1% respectively. See page 344 like more information. So this is a figure 16.3. Heme synthesis occur in the mitochondria of the developing cell. Hemoglobin synthesis, transferrin attached to the surface receptor on development cell. Iron is released and transported to the mitochondria, where it combines with the protoporphyrin to form heme. Protoporphyrin itself is manufactured from glycine and succinyl-CoA. Heme combines with an alpha and beta chains formed on the ribosomes to make hemoglobin. Heme synthesis occurs in the mitochondria of the developing red cell. The major rate-limiting step is the conversion of glycine and succinic acid to delta amino leuvinic acid, ALA. By ALA synthase, vitamin 6 is a coenzyme for the reaction, which is inhibited by heme and stimulated by the erythropoietin. Two molecules of delta ALA condense to form the biroll ring molecules of delta ALA. لا رينج اللي هي let's check it out.
Porphobilinogen.
Porphobilinogen. These rings are then grouped in 4 to produce the protoporphyrins, and with the addition of iron, heme is formed. Heme is then inserted into the globin chain to form a hemoglobin molecule. The structure of the hemoglobin is shown in figure 16.4. This is it, model of the hemoglobin molecule showing the alpha red and the beta blue chains by bisphosphoglycerate to 3-BPG binds in the center of the molecule and stabilizes the deoxygenases formed by cross-link in the beta chain methyl p propionic acid and vinyl. Hemoglobin function. The biconcave shape of the red cells provides a large surface area for the uptake and release of the oxygen and carbon dioxide. The hemoglobin becomes saturated with oxygen in the pulmonary capillaries, and where the partial pressure of oxygen is high and hemoglobin has a high affinity for oxygen, oxygen is released in the tissue where the partial pressure of oxygen is low and hemoglobin has a low affinity for oxygen. In adult hemoglobin, a heme group is bound to each of the 4 globin chain. The heme group has a porphyrin ring, which a ferrous atom with a ferrous atom, which can reversibly bind to an oxygen molecule. The hemoglobin molecule exists in 2 conformations: relaxed and taut, corresponding to the oxyhemoglobin and the deoxyhemoglobin respectively. The binding of one oxygen molecule to the deoxyhemoglobin increases the oxygen affinity to the remaining binding site. This property is known as the cooperativity and is the reason for the sigmoid shape of the oxygen dissociation curve, figure 10.3. of the oxygen dissociation curve. This is not 10. This is weird. Such as hydrogen ion, carbon dioxide, and red cell biphosphoglycerate. The binding of oxygen can also be influenced by secondary effectors such as hydrogen ions, carbon dioxide, and red cell bisphosphoglycerate. Red cell metabolism produces 2,3-BPG from the glycolysis, and binding of the 2,3-BPG stabilizes the T conformation, thus reducing its affinity for oxygen and increasing release of oxygen in this tissue. The P50 is partial pressure of oxygen at which the hemoglobin is 50% saturated, transported in the periphery, for example during the heavy exercise in anemia, and the P50 is increased to enhance oxygen unloading. Furthermore, the hydrogen ion and the carbon dioxide added to the blood cause a reduction in the oxygen-binding affinity of hemoglobin. The Bohr effect also helps in the exchange of carbon dioxide and oxygen in the tissue. When the primary limitation is in the lungs, for example in lung disease or high altitude exposure, the P50 is reduced to enhance the oxygen loading. A summary of normal red cell production and destruction is given in figure 16.5. So, red cell production and breakdown. The stem cells requirement for formation, hormones, metals, iron, vitamin 12, folic acid, and other vitamins. Matured red cells lifespan 120 days. Destruction in reticuli endothelial cells give rise of globin reutilized, and heme give rise to iron, which is reutilized too. What we have rest is bilirubin, transferred in plasma bound to albumin. Bilirubin glucuronide type enter hepatic circulation of the urobilinogen, urinary urobilinogen، بعدين stercobilinogen. Okay. Anemia. An introduction. Anemia is present when there is a decrease in the hemoglobin in the blood below the reference level for the age and sex of the individual. See box 16.1. Okay, so hemoglobin changes, right? Alteration in hemoglobin concentration may occur as a result of changes in the plasma volume as shown in 16.6. A reduction in the plasma volume will lead to spuriously high hemoglobin. This is seen in dehydration and in clinical condition of apparent polycythemia. A raised plasma volume produces a spurious anemia, even when combined with a small increase in red cell volume, as occurs in pregnancy. Anemia can be classified in a variety of ways. For example, it can be divided into due to decreased production or increased destruction, or alternatively into inherited or acquired causes. One common way of categorizing the various types of anemia is by the MCV, the main count volume, as shown in figure 16.7. Classification of anemia MCV. Mean corpuscular whatever. So the red cell appearances, and this is appearance of the bone marrow. Diagnosis: small cells microcytic, large cells microcytic, normal size normocytic. low MCV, high MCV, normal MCV. Megaplastic, normal plastic, iron deficiency, thalassemia or anemia of chronic disease, sideroblastic, vitamin 12 or folic deficiency, alcohol, increase of reticulocytes, for example for hemolysis, hemorrhage, liver disease, hypothyroidism, drug therapy زي الأزثيوبيرين ثيوبرين the normal acute blood cell loss, anemia of chronic disease, chronic kidney disease, autoimmune rheumatic disease, marrow infiltration, fibrosis, endocrine disease, hemolytic anemia. Let's get back. Anemias are therefore commonly described as hypochromic microcytic with a low MCV, normochromic normocytic with a normal MCV, macrocytic with a high MCV. While there is some biological rationale for this classification, some types of anemia can present in more than one category. Clinical feature: patients with anemia may be asymptomatic. A slowly falling level of hemoglobin allows for hemodynamic compensation and enhancement of the oxygen carrying capacity for the blood. A rise into 3-bpg causes a shift of oxygen dissociation curve to the right, so that oxygen is more readily given up to the tissue. Where the blood loss is rapid, more severe symptoms will occur, particularly in elderly people. Symptoms: the symptoms of the anemia are non-specific and include breathlessness, fatigue, headaches, palpitation, and faintness. Anemia exacerbates cardiorespiratory problems, especially in the elderly, for example angina or intermediate claudication may be precipitated by anemia. A good way to assess the effect of anemia is to ask about the breathlessness in relation to different level of exercise. Walking, for example, walking on the flat or climbing one flight of stairs. Signs: pallor, tachycardia, systolic flow murmur, cardiac failure. Specific signs seen in the different type of anemia include chylomicronekia, spoon-shaped nails seen in long-standing iron deficiency anemia, jaundice found in the hemolytic anemia. Bone deformities found in thalassemia major, and leg ulcers occur in association with sickle cell disease. Anemia is not a final diagnosis, and a cause should always be sought. Investigation: peripheral blood, a low hemoglobin should always be evaluated with the red cell.
AirPods. How about
Scene 9 may indicate the diagnosis. Where two populations of red cells are seen in the blood film is said to be dimorphic. This may, for example, be seen in patients with double deficiencies, for example, in combined iron and folate deficiency, in the colic diseases, or forming or following treatment of anemic patient with appropriate hematinic, where old red cells exhibit the changes associated with that deficiency and the newly produced cell have a normal morphology. Dimorphic population are also seen after blood transfusion. Bone marrow techniques for obtaining blood marrow are shown in the box 16.2 and on page 322. Examination of the bone marrow is performed to further investigate abnormalities found in the peripheral blood. Aspiration provides a film that can be examined by microscopy for the morphology of the developing hemobiotic cells. The liquid sample obtained at aspiration can also be used for immunophenotyping, assessment of presence or absence of antigen on the surface of the cells, cytogenic investigation, assessment of the molecular markers, and microbiological culture. While trifine provides a core bone that is processed as a histological specimen and allows an overall view for the bone marrow architecture, cellularity, and presence absence of abnormal infiltrates. The specimen can be used for immunohistologic histochemical investigation. Techniques for obtaining bone marrow: explain the techniques to the patient and obtained consent. Aspiration: the site, usually iliac crest. Give local anesthetic injection. Use special bone marrow needle which called Salah. Aspirate the marrow. Make smear with glass slide. Stain with Romanowski technique. Brill's reaction: acid ferrocyanate for iron. The trifine indication: dry tap obtained with aspiration, better assist of cellularity, for example aplastic anemia, better assessment of the presence of infiltration or fibrosis. Technique: site, usually posterior iliac crest. The aspirate is iliac crest. It doesn't matter if it's anterior or posterior, but in the trifine, usually posterior iliac crest. Give local anesthetic injection. Use special needle. Jamshidi: longer and wider than for aspiration. Obtain core of bone. Fix in formalin. Decalcify. This takes a few days. Stain with hematoxylin and iocine or reticuline stain. The following are assessed: cellularity of the marrow, type of the erythropoiesis, for example normoplastic or megaloblastic, and morphology of all cells, cell lineage, cellularity of the virus cell lines, infiltration of the marrow, for example presence of non-hemobiotic cells such as cancer cells, iron stores. I'm gonna discuss the types of anemia in a next video.